everyone. So my talk is not going to be as maverick as what Dipit spoke about, but what I'm going to be speaking on is slap tears and posterior labral tears. So that's a lot of ground to cover. I'll try to be brief and try to stick to time. So effectively, the concept of slap was described by Andrews in 80s, and the word was coined by Steve Snyder in around 1990s. Now, what was interesting is, conceptually, both these authors thought about a different mechanism to describe a slap, where Andrews spoke about the fact that it was avulsion of the biceps labral complex from the glenoid because of the pull of the biceps tendon, and where Steve Snyder thought that it was compression loading with the shoulder in a flexed and abducted position as in overhead athletes, causing the peel off. So that effectively makes us ponder about the pathomechanics of a throwing shoulder, which is well beyond the scope of this talk. But what you need to understand is majority of the slap tear patients would have a tight posterior inferior capsule. They would have an excessive external rotation that is at neutral position and an anterior capsular laxity. And that's something in rehab that you're going to concentrate lots on. So what is the orthopedic surgeon's perspective? Why is it so important? Because most of these slaps, which are the traumatic ones, happen in young patients and they present with significant pain and disability. So how do we diagnose them clinically? And that's why it's a big challenge, because none of these tests are really sensitive and specific enough to find that we are looking at a slap tear. There are various tests which are in combination with the labral tests which have been described. And the main ones that you would routinely do would be the O'Brien's and the jerk test, which I'll come to eventually. The classification, commonly what you would see is a type 2 and beyond, where there is just an avulsion of the biceps labral complex. A type 3 is the one with the bucket handle tear, and type 4 is where it extends into the biceps tendon. Gottsman and co-workers have further described various types depending on the extent of the labrum, but that's purely from theoretical perspective. But what you need to understand is disability of the biceps, which results in symptoms. So when you're looking at an O'Brien's test, there are two components to this test. In the first part, you crank up the biceps by around 15 degrees of adduction and you load the biceps. The same thing is then done in external rotation, and if part 1 is more painful than part 2, then you're considering it as a positive test. In a compression rotation test, you're actually loading the labral complex, and then you're causing a supination, and that can bring about further pain for the patient. All the axial loading tests are effectively variants of the same principle of axial loading. But if you look at all the tests, what you need to understand is that the pain is coming in from the biceps complex, and that's something that you need to pay attention. What else can you find in these patients? We spoke about posterior tightness, and normally you have an arc of range which is from 90-degree external rotation to 90-degree internal rotation. But in these patients, classically, you have the glenohumeral internal rotation deficit. So they start at around increased external rotation, and then they stop at decreased internal rotation. And this is what causes changes in biomechanics of the shoulder, resulting in a superior labral complex tear. So do we really need an MRI? If you look at all these tests which have been mentioned in literature, only the Job's test and the O'Brien's test are statistically significant. So yes, we are effectively looking at a clinico-radiological diagnosis. And what do you see on MRI? You look at the coronal planes, and where you look at is a cleft at the superior labrum, which can determine whether there is a slap tear. Sometimes, if it's not an acute tear, you might not really depict it as well, and that's where an abduction external rotation protocol is helpful, which causes the biceps labral complex to peel off, as can be seen on this arthroscopic video. So what does a systematic review tell us about how to diagnose slaps and how to go about it? So Ben Kibler had done this review, and what he found is diagnostic arthroscopy is actually the only way where you can really confirm that you're looking at a slap tear. And that's the reason the diagnosis still remains variable and inconsistent. How do I do a slap repair? You would debride your labrum very well to see to it that you have a nice bleeding edge. That's the beach chair position, that's your humeral head, that's your glenoid. Once you're done that, that's when you're going to use an indirect suture shuttle, and you're going to pass a thread across a loop across the labrum and shuttle it across with your high strength suture. Once you've done this, and you can fix it either by means of a knotted or a knotless anchor, but what you need to understand is that your labrum has to be securely fixed at the end of it. Now, there's a lot of controversy about the fact that do you want to fix it both anteriorly and posteriorly, because you don't want to over-constrain the biceps. And that's something which is an on-table decision that you would take looking at the biceps. So effectively, clinical evaluation is still a challenge. MRI is something which you would be convenient to diagnose a slap tear. Not all superior labral fraying is key to diagnosis. So if we talk about the posterior labral tears, the anatomy itself is different. Understand that the posterior labrum is much more hypercellular and vascular as compared to the anterior labrum. And amongst the dynamics, in addition to the rotator cuff, the posterior band of the IGHL contributes to significant stability. You have the circle concept where the anterior-superior tensioning results in a posterior-inferior capsule stretching and vice versa. Now, why is this important? Because clinically, when you're looking at these patients, you have to pay a lot of importance to scapula, because many times they have a winging of the scapula or a scapular dyskinesia. So if you look at the patient above, you can see that every time he comes down, he is actually having a clunk where the shoulder is subluxing posteriorly. If you look at the traditional tests, you have the posterior drawer, the load shift, the Kim test. Now, what you need to understand here is that in all these tests, you're causing an axial loading. So in a Kim's test, when you're looking to load the posterior inferior labrum, there is a firm axial loading, a 45-degree upward diagonal elevation, and that's where you're engaging the posterior inferior labrum. The same thing on a jerk test, you're going to do an axial loading, but you're going to come in a more horizontal plane, whereas in a Kim's test, you're going to come in a more oblique plane. What do you look for in an MRI? Something similar to what you would look for in an anterior labral tear. You're going to look for a cleft along the posterior aspect between the body of the glenoid and your labrum. Various terminologies have been described, like you have the alpsa anteriorly, you have the polpsa, which is the posterior labroperiosteal sleeve avulsion, which, according to many people, Kim's lesion is actually a precursor to a polpsa. So what is a Kim's lesion? You can see here that there is a posterior inferior labrum, which is usually always quite beat up. It's not like a robust tissue because it's an overloading mechanism. And you can see this cleft which is there, which can be significantly painful for the patient. Do we operate all labral tears or posterior labral tears? Well, what you need to understand is if there is a glenohumeral internal rotation deficit, you are going to give them a fair trial of rehab. Also, if you were to look at literature, it clearly states that all the studies stated that when there is a unidirectional posterior instability and the cause was traumatic, these patients always did better with an arthroscopic stabilization. So how do we repair a posterior labral tear? I want to quickly run through this. Effectively, you do a diagnostic scope, and then you're going to go ahead from the anterior-superior portal. And that's where you can see the tear. That's the posterior inferior labrum which is torn. You're going to elevate that labrum. Once you have elevated it and you have rasped it, you're going to create a fresh bleeding surface. So it's the same principles how you would do it in an anterior labral tear. So that's the elevation, that's the rasp coming in. And then you would go ahead and put in I prefer to use a knotted anchor. You retrieve one of the sutures from the anterior portal. That's your posterior band of the IGHL. Now you don't want to do too much of a capsular plication, but you would want to incorporate this band if the patient presents with posterior instability. The remaining steps effectively would remain the same, where you're going to shuttle it across, pass the suture across, and then tie it. So the end result looks something like this, where you got a robust repair on the posterior aspect. But beware, you're not going to take the multi-directional patients for arthroscopic stabilization because your results are going to be compromised. So always, all instability patients, whether anterior or posterior, do look for generalized laxity. If you were to complete your posterior labral tear talk without a spinoglenoid cyst, it might not be right. And that's why this is a combination of both a slap with a posterior labrum, and the fluid can insinuate, causing a cyst which can lead to a suprascapular neuropathy. The steps would remain the same. You need to decompress that cyst, and that's the kind of fluid that you will see coming across, and that would follow it up with a fine labral repair. So effectively, again, like the slap tear, in addition to your clinical suspicion, you will need radiology to confirm a diagnostic tear. High degree of suspicion is required. For large voluminous capsules, you may consider capsular plication in addition to the labral repair, but surgery is ideally meant for traumatic patients and not for multidirectional instability. Thank you.